So today we're going to be talking about URIs, but in particular this is, again, more about the episode itself. As I mentioned earlier, we have a principal accountable provider, so that everyone right now is being paid fee-for-service, but one entity, and sometimes it's the hospital, but in this case, for URI, it's a physician or a practice, will be the principal accountable provider. That person is often the person who sees the patient first or does the main bulk of the care associated with the episode. That person is the episode quarterback. It leads and coordinates the care. It's accountable for complications and for the efficiency of the episode. That person is then also potentially at risk for high-cost episodes, but also stands to gain from an efficient episode of care. So we will show you a little bit on a couple of slides how that works. In addition, on the next slide, besides looking at the cost effectiveness of the episode, we will have quality metrics built in so that in order to qualify for gain sharing, we want to make sure that it's not just inexpensive care, but care that actually meets some quality metrics. And unlike the hospital pay-for-performance program that we have, where we expect people to have to achieve an A or a B plus on their quality metrics, in this case, we want people to at least get a B minus, C plus, meet some core metrics at a basic level to make sure that they're meeting the core aspects of care that we expect the average provider to do. So we're not going to just reward any care, but care that meets certain quality metrics. Some of the quality metrics will be based off of claims data. Some of it will be based on recorded data. I believe on the URI episode, it'll be claims-based data for the most part. And we do have some occasional metrics that are just being tracked at this point in time. Next slide. So again, the episode works just like today. Most everybody will be getting fee for service. Their patients will seek care. Patients will get their care. If they get an X-ray, the radiologist will get paid. The chest X-ray will get paid for. If prescriptions are written, the pharmacist will get paid. They are, if you will, passive players in the episode. But on the next slide, you will see there will be a principal accountable provider who will also get paid for their services for office visits, etc. But at the end of the episode, their total cost of care on average will be calculated, and at the end of the year, their average cost of care will then be put into an array of compared to other providers, and their certain bonuses or potential risks will be shared. So on the next slide, you will see, and I think if you can, this will be, say at the end of the year, we'll say this is a URI episode. That's, say, a cost curve for all providers who are PAPs for a URI. So there will be high cost and low cost, average cost providers. Some of these providers will be, if you will, in the red zone, which you can see if you take the arrow down, if you use the mouse, right there, the pink zone. So if your average cost, if you say did an average of 100 URI episodes, for whatever reason, you may have ordered a lot of X-rays or prescribed a lot of antibiotics or a lot of brand name antibiotics, you might be in that pink zone. So you see there's an acceptable zone. You would be potentially at risk for 50% of the average cost above that above that acceptable zone, up to 10% of your total reimbursement for Medicaid, or if in case a private payer. So granted, that is the total cost of care in that zone, so that includes X-rays, antibiotics, blood tests. But the risk would be up to 10% of just your fee for service of your payment for what you received. That's going to be very few people. If you go to the next area in the zone between acceptable and commendable, those are folks that saw patients, ordered tests, ordered treatments, and are between acceptable and commendable. Your year of care occurred. Your average cost per episode is in that zone. Nothing much happened one way or the other. There are no risks. There are no bonuses. You go on to your next year. Sort of like Monopoly, do not pass go. You do not collect $200. You go to the next zone, commendable, where it says it's between commendable and gain sharing. These folks have seen the same category of patients. They have had the average cost per episode is lower than their peers in the acceptable or commendable range, and these folks will share 50% on average per case, and we'll show you what that means in a minute. And then there is a gain sharing limit. We've actually did not want to drive costs below a certain acceptable point. We were concerned that if people started going below the floor there, the gain sharing limit, they might be cutting corners. So we want to make sure there's a bare minimum. So while indeed these folks below that gain sharing limit will get gain sharing, they will not get a gain sharing below the gain sharing limit. So go to the next slide. What this means, if you look at the area there, if you were, say, in the below the commendable line, and let's just say, again, not for URI, in URI maybe say $20 and not $200 because of it's not surgery, but you have lots of visits. Let's say your average cost per episode was $20 below the acceptable line, but you had, say, 200 episodes, you would get 200 times 10. So you would have $20 below the commendable line. So 50% of that is 10. You had 200 episodes, so that would be potentially $2,000 that you would get as a gain sharing return to your practice, assuming you met the quality metrics. Conversely, if you go in the pink zone and you were $20 on average above the acceptable line, and you had 200 episodes, you would be potentially 50% of that 20, or $10 times 200, or $2,000 above at risk. And you would be, if your total reimbursement for colds was, let's say, $1,000 total, you would be at risk for 10% of that, or $100 total. So there is a limit to what you would be at risk for. On the other hand, you can see that the risk sharing is quite a bit lower than the gain sharing, and that those who are effective primary care docs in this episode, not only are they getting their fee-for-service office visits, but they're potentially going to get an extra $20 per office visit, which actually is almost 50% of the average cost of an office visit, give or take a few bucks, depending on how many office visits worth a cold. So here we have an opportunity where primary care physicians are actually going to get a bonus dollars rather than just more volume. The better docs are actually going to get paid more. Now, granted, this also applies to anybody who sees a patient for the first time for a cold. So if you are an ER doctor, this includes you. Or if you're potentially an ENT doctor who sees a cold, it applies to you. So anybody who is the first contact for a patient for a cold and then has a 30-day window, all the care within that 30-day window applies to you.